Well, I would like to share with you a case which I did just a couple of days ago. It's nothing spectacular like Andre is doing every time when he's using retrograde access. It's more or less an everyday case showing the use and the benefit of a new technology, which I will not yet disclose. So this is the baseline angiographic finding. A little bit background information about the patient. It's a female patient, 89 years of age, with a newly developed wound at the second and first toe of the right leg, with rest pain at night. And what you can see is a very diffuse disease. That's the femoral bifurcation. That's the SFA distal to the 6 French sheaths, which was introduced in an antegrade fashion here. That's the sheath. And this is the severe calcification, which was visible under fluoroscopy. You can see here the occlusion of the popliteal artery. There is some collateral vessel originating, which is then providing collaterals to the anterotibial, and then after or distal to an occluded tibioperoneal trunk, also to the peroneal artery. So I would say it's no doubt that this is something what we usually consider as being the major challenge in interventional treatment. This is severe calcification, intraluminal calcification, and also medial calcification. That's the outflow. That's basically the distal part of the tiny peroneal. And here we have the anterotibial artery, which is the only foot-providing artery at the end. So key questions that have to be asked every time if you are targeting such a kind of lesion is how to cross the lesion and which treatment options are available. So first of all, who believes that this is possible to cross such a lesion in the true lumen? Or is this a clear subintimal case? So who would assume that this would end in a subintimal recanalization attempt? You can raise your hand, it's easy. And who would believe that it's possible to stay true lumen? That's the minority. So treatment options, calcification. What do we have? Well, of course, we can debulk, but this is a very diffuse long lesion. I believe most interventionalists would not consider as rectomy. What I will discuss here is lithoplasty. And this is, I would say, one of the interesting cases where we will see the benefit of this kind of treatment. Lithoplasty is something which is still investigational in the US. We are running an international study just comparing the combination of lithoplasty with DCB against DCB as a standalone therapy in calcified lesions. And the treatment basically is considered to treat calcium, to fracture hard calcium, and in order to facilitate balloon angioplasty and to reduce recoil later on. So basically what happened, and this is what I'm not going to show, is I was using simply for French catheter a 35,000 glide wire, and it was possible to get across the lesion in the true lumen. Probably it's worth to go back and to explain why it was possible to get across this lesion in the true lumen. The main important step here to stay true lumen is to get access into the occlusion in the true lumen. If you are once in the true lumen here entering the CTO, then it's very unlikely that the guide wire will get out in the subintimal space, because this is a more or less concentric tube, concentrically calcified tube, and if you enter into the true lumen at the very beginning, you have a good chance also to stay true luminal during the entire crossing attempt. So basically what was done, the entire femoral popliteal lesion was step by step treated with lithoplasty using the shockwave technology. So that's low pressure at the very beginning. This is the transition area here into the anterotibial artery. So it's a 4 millimeter balloon. This is going to 6 atmospheres. So step by step, this was dilated with the shockwave balloon, followed by drug-coated balloon angioplasty, and ending up with this result, showing, I would say, an unexpectedly good outcome in this severely calcified vessel segment without the need of any scaffolding. At least the acute outcome before discharge was very promising, so there was no sign of residual stenosis. And this is the study I already mentioned. This is PAD-3. It's a randomized controlled study, very ambitious because it's not so easy to find the appropriate patients. Lesion length is ranging from 7 to 15 centimeters, and it must be a moderately to severely calcified lesion. And the plan is to supplement the study in the near future by a single-arm study, a kind of registry, enrolling patients that dropped out of the randomization scheme in the near future. So this was the case, not very spectacular as mentioned, but I believe it's a very important case with regard to illustrating the background and the significant benefit of the use of lithoplasty in the near future.
If you hadn't been able to get across, antegrade, would you have, rather than push, would you have stopped and then done pedal access and come retrograde?
Yeah, definitely. If this would have been ending in a subintimal space, the next step would have been to use the anterior tibial retrograde stick and trying a bilateral access to the lesion. And finally, if this would have ended as a subintimal procedure, I wouldn't have used lithoplasty. What we have learned so far is that the most efficient application is in the true lumen, so meaning staying concentric with this kind of treatment. So in a subintimal recanalization case here, the next step would have been most likely to use interwoven nitinol stents, the Supera stent, which has been shown to be very effective also in this popliteal location.
Just a question.
Yeah.
About the tractability of the balloon to such a calcified lesion. We're part of the trial. We haven't started yet, so we haven't used it in clinical practice. So is it very difficult in this type of calcified lesion? And what was the access site that you crossed this lesion?
Well, as mentioned, it was an antegrade stick through the right groin, so right antegrade stick. And basically, I was able to cross the lesion with a 35,000 guide wire. I followed the guide wire with a 4 French catheter, so I created already a lumen. And then it was pretty easy to advance the shockwave balloon into the distal part of the formal occlusion. By the way, it's worth to mention that this device is running over a 14,000 guide wire, and the profile is excellent despite the application of those radio frequency energy emitters. The catheter itself is relatively stiff, and this gives a very good axial pushability of the device, so you can even approach CTOs directly without the need of pre-dilatation.
So there's one other, that's an excellent case. One other piece of information, you mentioned it wasn't approved in the U.S. It actually is cleared for use in the U.S. and commercially available.
Okay.
The trial's being done to look at comparisons and look at DCB effectiveness, as well as gather economic data. So the trial is actually a very important trial, but the device is actually available off trial use.
Okay.
Thank you.